Hello, everyone, and a warm welcome to all of you joining this APMEN Tech Talks webinar. The webinar is hosted by the Asia Pacific Malaria Elimination Network, APMEN, Surveillance and Response Working Group. Since 2017, APMEN has proudly hosted APMEN. This robust structure enables APMEN to further strengthen national malaria programs by bringing more resources through shared technical expertise, fostering peer-to-peer learning and evidence generation, which support APMEN's high-level advocacy for political action. So I'm Professor Richard Maud. I'm the co-chair of the APMEN SRWG. And next, I'd like to invite Dr. Xiaohong Li, Technical Officer at WHO GMP, to moderate this APMEN SRWG Tech Talk on country case studies, preventing the re-establishment of malaria transmission.
Good morning. So I am Dr. Xiaohong Li, Technical Officer at the WHO Malaria and Neglected Tropical Diseases Department in Geneva. I will moderate this webinar. Thanks, Richard. Prevention of re-establishment is a global malaria goal as defined in the Global Technical Strategy for Malaria 2016 and 2030. After malaria elimination, countries and subnational areas face the continual challenges to prevent re-establishment because the continuous importation of malaria, the presence of malarial vectors. Malaria-free countries and subnational area must maintain a fully functional surveillance and response system in order to mitigate the risk and maintain malaria-free status. In order to support countries to prevent re-establishment, WHO has recently released the first global guidance on prevention of re-establishment of transmission. This guidance highlights the key principles, strategies, and good practices for prevention of re-establishment. On September 25, we held a webinar to introduce this new guidance. Today, we will shift our focus to the field. So we have invited 3 countries across the Asia Pacific region to share their experience, practice, and challenges for prevention of re-establishments. So these 3 countries, they come from different settings. We have one country that have been certified malaria-free a few years ago. This is Sri Lanka. We have Bhutan that's actively preparing for certification. Fingers crossed they will be certified. And we have Cambodia, which have made impressive progress towards malaria elimination and therefore working actively to prevent re-establishment of transmission as subnational area. Elimination and prevention of re-establishment must go hand in hand in order to consolidate the progress and eventually achieve and maintain malaria elimination. So it's going to be a very interesting combination of countries. Before we begin, let me just quickly go over a few housekeeping notes. So this webinar is being recorded and the recording will be made available. We will provide a link to access the recording in the chat box. We are not going to take live questions during this webinar, but we encourage you to submit your questions in the Q&A box. We will do our best to address as many as possible during the Q&A discussions. When submitting your question, please start with the name of the panelist you are directing it to. This will help us route your question more efficiently. So as I said, we'll have 3 speakers delivered back to back, followed by a dedicated Q&A section. And toward the end, we will have a quick poll. So our first presenter today is Dr. Paul Li. He is the Deputy Chief of Technical Bureau and head of the malaria unit at the National Center for Parasitology, Entomology, and Malaria Control, Ministry of Health, Cambodia. Our second speaker is Dr. Indiwari Gunaratne. She's a consultant community physician and medical entomologist at the Anti-Malaria Campaign, Ministry of Health, Sri Lanka. She's a medical doctor and holds a master's degree in medical entomology and applied parasitology. Our last speaker today is Top Gay. He is a program analyst at the Vector-Borne Disease Control Program, Department of Public Health, Ministry of Health from Bhutan. So let me just invite our first speaker, Dr. Polay. He will present prevention of reestablishment of malaria transmission in Cambodia. It is a pleasure to have you here, Dr. Polay. The floor is yours. Thank you.
Thank you, Dr. Sehong Lee, and thank you for all organizers. Good afternoon, everyone. My name is Polly, working for National Malaria Control Program. Today, I would like to share the presentation of the PR in Cambodia to all of you and some pilot experience from Cambodia. I have three main points to talk this afternoon. One is elimination and PR planning and PR pilot in Cambodia, as well as Cambodia PR system for apply in the next year or after elimination. Here I would like to share some malaria update situation in Cambodia. The Cambodia has no malaria deaths in 2018 and no malaria falciparum case, malaria species in 2023. And PY health declined a lot. This is a progress toward outer malaria elimination in Cambodia. And you see in the graph after 28 years, that outer malaria in Cambodia is in 1997 up to 2025. We have divided into main part of the malaria data in Cambodia. Before apply strategy malaria elimination in 1997 up to 2011 is the year of the control of elimination in Cambodia. The case every year in average 120,000 per case, and that case 400 is a lot of the malaria case and death during before apply malaria elimination strategy. After we are elimination strategy since 2012 up to 2025. And the first 6 years after applied strategy, the malaria case dropped to 51,000 cases and that only 12 deaths per year. But after 6 years of elimination, malaria death is now happen in Cambodia since 2018. And up to now, last 5 year case, and especially in the first 6 months of the 2025, there are only 22 cases of malaria in Cambodia. Here is the nationwide PR for applying start from next year, 2026, after we are elimination by the end of this year. Based on WHO pre-certificate, the country must be held no malaria case for 3 years consecutive year. And the Cambodia on track to 0 case by the end of this year and plan to apply POR or to get certificate by 2029. And we are planning to prepare documentation for the certificate as well. Up to now, National Marine Control Program of Cambodia has developed 2 guidelines and 1 protocol. Is the guideline for prevention of re-establishment and the guideline for documentation to support the malaria elimination. And also we have developed another one, the subnational verification for apply in the country before we get into request certificate to WHO. So we need to be verified by in the country by a national first, and then we continue to apply certificate to WHO. This is the process applied in Cambodia. And in 2024, national program and WHO in Cambodia has pilot PO certification and for capacity assessment in 2 provinces in Cambodia. One province is about Cambodia, Thailand, and another one in the middle of the country. The pilot of the PO is we have 2 objectives to test PO certification through the develop the questionnaire and ask and interview the village involved person in the village. And the second PO capacity assessment to the health staff. So we apply in the 100 village and 2 province, 2 rural hospital and 10 health center, and also include community health worker 15 village as well. The result of the certification village, we see that all villages are classified as non-receptivity and low imported case, no imported risk. The primary vector was not present in the village that are pilot. And those villages are not in the rank of the 5 kilometers of the forest. And the village leaders were unaware of the local mobile population because they did not, how can I say, notify on that why we are, during we ask questions, and chiefs of village not aware about that. And some of the village are not crossed to the border, so that's why they do not well understand and well know about that. And the data available in last 10 years from the health facility and the community for the malaria. And we need to be revise also the questionnaire more update for the fit of the certification. This is the certification that we are finding from the PO pilot. And the capacity assessment as well. In this in the period of the pilot, the provincial and the health staff well known and understanding about malaria quota. They are applying the malaria elimination stage. And microscopy is a limit for the some remote or some low case of the malaria. Regarding to the symptom and the malaria knowledge, they well understand. As I mentioned, they are implement of the malaria elimination. So mostly they are well understand regarding to the malaria. But for the community health worker, some of them forgot because they are limit of the knowledge and no malaria case of a little bit long time, 2 or 3 years. The village malaria worker forgot some of that kind of the symptom. Regarding to the prevention, they are well understand long-lasting infection like that is the best one for the practice of the malaria prevention in the Cambodia. This is for the malaria PO for apply in the next year. Is the criteria Cambodia PO approach is to apply. One is the imported risk, and the second in the receptivity. And the imported risk criteria, there are 3-4 criteria: proportion all international imported case, proportion all domestic imported case, bordering transmission area, region of the port entry. For the receptivity, we focus only to the presence of the primary vector and the number of local acquired and the report from this. These are the first step of the Cambodia PO approach to assess for resource area for PO. Here is the result of the malaria potential to use determine risk data and which are used into the prevention and response for intervention. I do not read detail of that, or I explain only there are two tables. For one is for the classification, and another one table is for prevention and response. For the classification regarding to imported risk and receptivity, we are divided to 9 category. And for the prevention, we are respond to the classification of each classification as well. Regarding to the response, we are respond to be based on the classification of the case. And you can see, or I can share later on, the detailed activity one by one. So using the time limit, I do not read detail of the response activity or prevention of activity. I will see in that screen. You might understand some of that. Here is the draft of the surveillance for PO. It looks like the final draft. Even is the draft, but it looks like the final. We apply the same, similar to the malaria elimination surveillance, but it's a little bit different in the classification and the response. Because elimination, we are more detailed regarding to the internal case and some more detail by in the country. But in this surveillance PO, we are focus on the imported case, induced, relapse, indigenous, and introduced. All these case classification, we have the deep focus investigation one by one as well, and we respond to the case classification as well. This is my summary for the surveillance during the PO application. Here is the last slide of my presentation. Is the successful prevention of the PO also require involved across administration, administrative level, especially one is vigilant and intersectional collaboration, social behavior change, BCC, cross-border collaboration, training capacity staff during the malaria elimination, quality assurance monitoring and evaluation, program restructure, and the last one is political and financial commitment. This is the need to be involved across administrative during the apply in PO. That's it for my presentation and
Thank you very much. That's excellent presentation. Very impressive progress. So Cambodia is not only making impressive progress towards elimination, not also making significant progress on prevention of reattachment. Thank you very much, Dr. Poli. Next, let me invite Dr. Indiwari Gunaratner from Sri Lanka. She will share her insights on beyond elimination, how Sri Lanka maintains malaria-free status through a whole-of-government approach. Very pleased to have you here with us today, Dr. Gunaratner. The floor is yours.
Good day to all of you. Thank you so much for giving this opportunity to showcase post-elimination efforts we have adopted to sustain elimination of malaria in Sri Lanka. So I will explain beyond elimination how Sri Lanka maintains malaria-free status through a whole-of-government approach in this presentation. I will explain the strategies we collaborate with and challenges we face to prevent re-establishment of malaria in a disease-eliminated setting. Sri Lanka, slides. Sorry. Can you see my slides?
No.
Not currently. I can share mine as well, Dr. Indiwari. Just let me know.
Sri Lanka certified malaria-free by the WHO in 2016. The last indigenous case was reported in 2012. So now it's been 13 years we sustain this elimination status. So we reached this achievement after decades of consistent efforts adopting different mainly treatment and vector control strategies along with all challenges of insecticide resistance time to time. So this graph shows our history from 1911 to 2012, how the caseload was controlled with adapting different strategies. So with all these efforts, Sri Lanka eliminated malaria management phase. So sustaining achieved elimination is challenging, and it's challenging, more challenging than eliminating the disease. Since elimination, continuously imported cases were reported, and we experienced one introduced case in 2018, introduced through a migrant Indian laborer, and one transfusion-induced case in 2021 through a missed screen blood pack. So there were 3 deaths during past few years, one each in 2023, 24, and 25. These were among Sri Lankan returnees from malaria endemic countries. So on average, around 50 imported cases are reported annually, and in 2025, so far, there were 39 cases with 1 death. So we adopt many strategies to sustain elimination status. So sensitive case detection and thereby rapid containment is done through a strong surveillance and rapid response system. So we have 24-hour functioning hotline where any medical facility can reach us to get support for rapid diagnosis and treatment with high quality drugs. So when suspect cases are reported, anti-malaria campaign ensure rapid diagnosis within 1 hour. If the patient becomes positive, immediately treatment is started by anti-malaria campaign medical corps at any corner of the island. So patients are managed in ward and kept under LLINs. So during the case investigation, medical officers take a detailed history of the patient and do contact tracing and identify travel agents and high-risk groups in the area of the patient. So thereafter, reactive surveillance is initiated, and it includes parasitological surveillance within 1 kilometer radius of the patient's night stays with symptoms, and entomological surveillance within 48 hours to assess the transmission or transmission potential to initiate immediate action, such as community awareness, treatment of positives, and vector control. Use of digital tools for this rapid response. These are the surveillance systems maintained at anti-malaria campaign, and there is a case-based surveillance system, risk group surveillance system, parasitological and entomological surveillance systems. So these are done either as routine surveillance or reactive surveillance to positive cues. So we follow up patients daily to see the parasitemic clearance and there onwards to assess the drug resistance. So continuous readiness of country for outbreaks is also another strategy we adapt. So this is done through making available facilities and access to them around the country, and also constant field staff to ensure rapid diagnosis and treatment. So we have made available guidelines, SOPs, and scope of work for all techniques and procedures to give high quality service. So target approach to high-risk population is another important strategy to sustain elimination. So our main risk group is the travelers who are either Sri Lankans or foreigners to all these endemic countries. 76% of imported cases in 2024 were Sri Lankans. So the main travel groups were forces and police officers returning from UN peacekeeping missions and trainings, and gem traders traveling to African countries, and migrant workers returning from malaria endemic countries, pilgrims to India, Nepal, and Myanmar, and tourists who travel to malaria endemic countries and returnees from South India. So therefore, the main stakeholders we consider to collaborate are Ministry of Defense and Police, Association of Gem Traders, Ministry of Buddha Sasana, who arrange pilgrims, travel agents, and UNHCR for screening of refugees and asylum seekers, International Organization for Migration, who does inbound health assessment for people who apply residential visa, and Department of Immigration and Foreign Employment Bureau. A strong cross-sectional partnership through multi-sectoral whole-of-government collaboration between stakeholders is important to ensure border health and travel surveillance and targeted approach to high-risk populations. In this whole-of-government approach, while anti-malaria campaign carry out all implementation activities according to the National Strategic Plan, we maintain a close collaboration with other health partners, non-health government partners, non-government agencies, and civil societies to sustain elimination status of malaria in the country. So within the Ministry of Health, epidemiology unit supports routine notification, quarantine unit supports port screening, surveillance and vector control in ports of entries, and Health Promotion Bureau supports anti-malaria campaign in community awareness. Provincial and regional health authorities oversee all ground level implementation activities, and Border Risk Assessment Center supports in sharing information of all immigrants from African countries, which enable rapid follow-up on screening. So we have good collaboration with Ministry of Defense. All officials who go on peacekeeping missions are provided with pre-deployment deployment advice, chemoprophylaxis, and all are screened on return. So we also provide them with treatment. As our main high-risk group includes gem traders, seafarers, and pilgrims, we keep good collaboration with Association of Gem Traders, travel agents, and Ministry of Buddha Sasana to get referred all these travelers to malaria endemic countries and provision of chemoprophylaxis. Once they come to obtain prophylaxis, we get them registered and then follow them up for screening on return. So we have direct communication with Department of Immigration and Department of Airport and Aviation. Because we are an island, we have few ports of entries. So we don't have land borders. So malaria messages are displayed on immigration website, and we have placed awareness messages at the ports of entries. And there is port health office also established at all these ports of entries to make services available for travelers. So we also get support from local government authorities and vector control for control and community awareness, and also the religious leaders again for awareness, providing technical guidance and logistics support, especially for drugs and diagnostics, and financial support. And also UNHCR and IOM support us in screening and surveillance of refugees and asylum seekers, and IOM again for inbound health assessment. So we also have a good partnership with private hospitals and laboratories, and this is a huge strength for us for early diagnosis of patients seeking care in the private sector. Anti-malaria campaign is supported by a group of independent experts through an established technical support group. So this group is comprised of experts on epidemiology, malariology, parasitology, pharmacology, internal medicine, and entomology from universities and elsewhere. So universities also support us in carrying out operational research, and also media helps wider coverage of malaria-related messages to the public. So all this highlights that even though elimination required health leadership, prevention of re-establishment needs continuous cross-sector collaboration. So maintaining high technical capacity in epidemiology and vector surveillance also supports assessing receptivity and vulnerability, importation risk of the country for malaria. So we have online data entering platforms for entomological surveillance, and data on monthly are entered and monitored. So main challenge we face is the receptivity. So we have both primary and secondary vectors, and they are abundant in formerly malaria endemic districts. So still the receptivity is there for malaria transmission in the country. So with the importation of cases through increased global travel, labor migration, and cross-border movements create continuous risk and making the country vulnerable for outbreaks. So surveillance fatigue among clinicians and field teams over years with zero local transmission gives false sense of risk-free. So there is delays in diagnosis of patients, where we also experienced deaths recently. And we during last 3 years, we got one each death in each year. So it is challenging to keep all these health staff vigilant for malaria reintroduction, and we continuously carry out training, awareness programs, and even send monthly SMS alerts to keep them vigilant for early detection of malaria cases. So declining public awareness is also challenging and we have to take efforts to make malaria an unforgotten disease and integration across vector-borne diseases. Uh, uh,
Sorry,
remain always challenging.
sorry, Indy, worry. We can't hear you
So
very well.
our recommendations to other countries.
We
Dr.
lost her.
Hong, I think we
Yes.
might have lost Dr. Indiwari. She
Yeah.
has about 3 more slides left there. So I think we can have her come back in a second if that works for everyone as well.
Yeah. Yeah, I
Give
agree.
it's
We
just
wait, or we move on, and then we will.
I think maybe we move on in case it takes her a second to join back in, if that's okay. I think there's only 3 slides. We can have her come back and deliver her final remarks when she's back.
She's back.
Okay.
Good.
Sorry, I was disconnected. So our main recommendation to other countries are to keep case-based real-time reporting linked to rapid response teams, formalize cross-agency SOPs for screening and information sharing, and maintaining diagnostic lab entomological expertise and quality of services, and keep clinicians trained on early detection of malaria, and to consolidate malaria PUR into national. So these are the recommendations. So that's all from Sri Lanka. Thank you so much.
Thank you very much. Very impressive presentation indeed. And we also take note of the challenge of Sri Lanka. I think the country is doing pretty well, but we noted that some challenges. Thank you very much again. We will discuss that in the Q&A section. So let's move to our final speaker, Topgay from Bhutan. Dr. Topgay, are you ready?
Yes, Dr. Hong, thank you so much. I'm so sorry that I could not able to connect properly in the
No
first
problem.
few minutes. Our internet connection was not that good. So I feel very sorry for not being able to connect in the first place.
No problem. Go ahead, Dr. Topgay. The floor is yours.
Thank you so much for giving me an opportunity. I would like to thank APMEN Surveillance Working Group for giving us an opportunity to make a presentation of the Bhutan case on malaria elimination and sustaining the prevention of reestablishment. This next slide. So these are my outline of presentation. So please go ahead. So if you look at the boundaries where Bhutan falls, it falls between the two big countries, China and India. India covers southwest, southeast, and south, and the China covering the northern border. So usually with China, we do not have malaria because the areas are very highland and then a very cold place. And from India, we have a border with the two Indian states which are still malaria endemic, Assam and West Bengal. Sikkim side, we do not have much malaria. Arunachal also, that borders with Bhutan, is in the highland, and we do not have much malaria cases. So the concerns that we have with the border of Assam and the West Bengal of the Indian state. So these two states are still malaria high burden area, especially in the border area. So these are big concern for us, especially in sustaining the eliminations and prevention of reintroductions. Next, please. So if you look at the background, malaria program is one of the oldest program in the country. It was there with us since 1962. And as the progress, as the country move forward, the name of the program has also shifted as per the requirement. So you can see it has been, first it was malaria eradication program, then it was national malaria control program, then vector-borne disease control program, and it was shipped to the elimination status as we move for malaria elimination. And also we are looking for other vector-borne disease elimination as well. And again, in 2023, when we have a reform of the health sectors, it has been renamed as the vector-borne and climate-sensitive disease. So as the country move forward with the shift of the priorities, the name of the program culture has been also changed. Next. Next, please. So now if you look at the national strategic plan for the malaria and other vector-borne diseases, so basically our vision is to make the vector-borne disease no more a public health threat in a country. So our mission is to prevent, control, eliminate, and eradicate, if possible, of the vector-borne diseases of public health concerns through formulations and implementation of evidence-based policy and strategies. So currently, we are focusing our goal to achieve the malaria elimination, to reach the zero indigenous malaria case by December 2022 and obtain WHO certification by 2025 was our aim as part of the National Strategic Plan. Next, please. So now if you look at the strategies of the malaria, we are focusing especially on the disease management and of course the vector management. And then of course, then we look for the supportive interventions, especially for the awareness, control, prevention. In the disease front, we look for the early diagnosis and the prompt treatment and the referral services referral services if at all the patient require the referral, epidemic preparedness and response, the good surveillance system, and of course the drug efficacy monitoring is the part of the disease management. And in the integrated vector management front, we look for the control measure like indoor respiratory spray, larvacidal fish, source reductions, LLI distribution, insecticide susceptibility tests, and of course bioassay tests for the other control measure as well, like IRS and the LLI. Supportive fronts, we look for the behavior change communication, public-private partnership, intersectoral collaborations, the expansions of the HR requirements, and the awareness capacities in other sectors. And then we also focus on the operational research, few that we could able to do it. Then monitoring and evaluations using GIS mapping and the real-time monitoring of the cases. So overall, everything falls under the surveillance as a core interventions for all these activities. Next, please. So now if you look at the malaria epidemiology, the malaria, Bhutan reached pre-eliminations since 2012 onwards, and we are still struggling with few number of cases. So actually, Bhutan reached zero indigenous cases starting from 2022. Our last indigenous cases was reported in November 2021, and since then we do not have the indigenous cases reported. However, in 2024, there was an upsurge of malaria cases in the other side of the border, especially close to the border area, where they have a very massive outbreak, where Bhutan has been impacted with the cases, as our borders are too close. And then we have a joint town, joint city, the joint villages along the border. So even with all control measures in place, we have seen the increased number of malaria cases. However, with the proper investigations and review, most of the cases were imported, and of course we have seen few number of introduced cases as well in 2020. Even in 2025, this year also we have a similar type of outbreak in the other side of the border. Even in West Bengal this year we have a outbreak, and there were a few army outposts personnel were reported in our area as well. So we are working very hard to sustain, but sometimes it is very difficult to see. And if you see the species predominant is the P. vivax cases. Next, please. So you can see that the P. vivax dominate the malaria cases. But in 2023, you can see almost like 45% of the malaria positive cases were P. falciparum also. But in 2023, when the UN peacekeeping force returned back to country, we have captured when they are in the quarantine areas in one of the army headquarters in Thimphu, where 10 of them were positive. So because of that, all PF cases are from the South Africa, the UN peacekeeping force, when they returned back from the peacekeeping duties. Next, please. So you can see the seasonality pattern. We are almost, the malaria seems controlled, but in 2025, we have seen a spike of malaria cases in the month of August, September, October, November, till December, we have seen the malaria cases, spike of malaria cases in 2024. But this was all because of the outbreak in other side of the borders. Now, if you see the foci by district, we have reached the most of the districts. We have eliminated malaria quite a long time back. That we have been struggling with one district, Sarbang. We still be able to achieve the 3 years, but sustaining the preventions of reintroduction and reestablishment, I think would be a challenge unless India move for the elimination in that 2 states. Next, please. So the vector, the suspected vectors on the Bhutan is Anopheles culisiphysis, and Anopheles pseudohermoria, and the vagus. So in some area, the vagus are prevalent, and in some areas, culisiphysis are present. So these 3 are the predominant when we do the vector surveillance in the case-based surveillance, as well as when they go for the routine vector surveillance. Next. So these are the core interventions for the vector-borne diseases, actually, for the preventions. So we have a long-lasting net. Every year, we usually cover all the mass, the risk population mass distribution, followed by the replenishment every year based on the net attrition rate. Second is we also provide IRS in the border area where there is a joint village, joint towns, continue to with the 100% coverage of LLI. Then we also conduct the routine vector surveillance, insecticide resistant monitoring. So basically to see whether our control methods are effective or not. For around 1 year back, our net efficacy has gone down. And because of that, many of the chemicals are resistant to the net. So this year we are procuring the PBO net, which is a double insecticide net. So we are hopeful that with that intervention, the cases in the border area would also fall accordingly. Then we also have early diagnosis and the prompt treatment. We do a follow-up, drug efficacy, and of course, the community participation and ownership. We continuously go on engaging the communities in the malaria control and prevention activities. Next, please. So these are the social mobilization and community engagement that we really do. We try to involve the agencies that are more on the health related issues, especially like the Red Cross, then the Orange Days, that the soups, where they usually provide the voluntary services in any kind of national requirements. So then we also do the kind of vector management in the areas through mobilization of the communities. Next, please. So the policies and intervention for sustaining malaria elimination, I think we have a strong political commitment for malaria elimination. And then the malaria is an immediate notifiable disease. We also admit all the malaria cases for 3 days for the compliance of drugs and then follow up. We also do the 137 strategies, case notification, case investigations, and the response. And these are real-time monitoring through the web-based reporting. Identify DOTS provider for PQ for 7 days. So after the 3 days treatment in the hospital and the 4 days, then we identify the DOT provider, especially the village health workers or the community action group, or the family. If it is in the school, then we monitor. The school health coordinator usually provide the drugs. Then the case follow-up, we do 0, 1, 2 days and 14 days, 28 days for PF and the PYVX, and continue 3 months and 1 year for PYVX cases. So we do the PYVX cases follow-up till 1 year. So community engagement in response of malaria, local leaders, community action group, we are engaging every time. Whenever there is a malaria cases, we activate them to do the control and preventive activities in their level. Every health facilities has mapped their malaria hotspots area, and then they also do proactive cases and the surveillance vector and the case finding in these high-risk areas. These are the kind of policies that we have kept on, and then it will be continued even in the prevention of the reintroduction and reestablishment as well. Next, please. So the border malaria, I just want to highlight a little bit on the border malaria, as many of our cases are just to the border. You can see that why border malaria, the mosquito has no boundaries. Our people live very close, porous international borders with no restriction of population movement. Malaria cases were confined to the international border, especially the village that are bordering with the other areas. And the army and the foresters, when they do the patrolling in the outpost areas, and the frequent outbreak along the border, especially in the border areas. And then we are in different malaria stages. The Indian states are still in the control, and then you can see these are the borders. You can see we just have a line in between the town and the villages. So with that, I think it is very difficult to control the malaria in the area, because when we do the foresight investigation, half of the foresight falls in the other side of the border. So this was big concern that we have in prevention of reestablishment. Next, please. So the good practices of the cross-border collaboration that we have been establishing is at the regional level. There is a facilitations from the and coordinations of the cross-border collaborations at the regional level, especially the WHO and the SRCM is coordinating the regional level coordinations. And we also initiated this informal local social network among the malaria workers and leaders along the border areas to discuss on malaria case reports and alert each other for being vigilant. We also initiated the cross-border referral of malaria cases across the border, especially the day worker if it is diagnosed in our health facilities. We provide them with a full course of treatment, and then we send the malaria patient back to the other side of the borders and inform the other border health workers to support us. We also conduct a joint health camp during the important event, especially when there is an important event like birthday celebrations and also the festival camp. We do the kind of health camps in both the areas. Cross-border joint screening and awareness during the outbreak. Last year we have initiated, and this year also we are going to do the same in the border area. So these are the good practices that we have in our area. Next, please. So you can see this cross-border collaboration. It was initiated by WHO. Then we have an exchange program across the border, visiting each other's, and then of course conducting the health camp in the event where there is a requirement. So in one of the events, we have also the main challenges. Next, please. The main challenges are the emerging of other vector-borne diseases. So these are the big concern because malaria program is vector-borne disease control program is not looking only malaria program, but also other vector-borne diseases. So we sometimes face challenge with the emerging of other, especially the dengue in the seasonal transmission period. Cross-border transmission is the big concerns with all these porous border. We also have a human resources shortages at the technical level, technical capacities level, both at program and at the field level. Maybe in the long run, we might feel pressures of the funding because gradually the donors are withdrawing for the funds. So far, we are comfortable with the global fund supporting the program. Challenges in behavior of the communities. When the disease become rare, the communities also become complacent in using the control and preventive measure. These are a few challenges that we see. Next. So the way forward is that for the capacities, I think we have already initiated the pre-service training for medical entomology and parasitology technique training course in the university. So the first batch of this training will graduate in June 2026. So gradually we will be filling in with this human resource in the field. And then we also use the existing vector-borne disease capacities through the standard development of treatment protocol, SOPs, and training of the in-service health workers. Next, please.
Sorry, Dr. Topke, and can you be a little bit quick?
Yeah. Okay.
Thank you.
And also we are feeling stronger involvement of the technical advisory group. Since we do not have a capacity, we have a technical advisory group for malaria elimination. So we are frequently using them for developing the sound guidance for the program, district malaria managers, and also development of SOPs, M&E plans, and the oversight of the program implementation as well. Next, please. And then the strengthening regional coordination mechanism for cross-border. I think we really need to strengthen this to have an impact on the border malaria in the long run. Next, please. So this ends my presentation, and then if there's any questions, I would be more than happy to answer.
Thank you. Thank you very much, Dr. Topke. We noted your challenges in the border. So I think we have finished the 3 presentation. Can I invite all the speakers to turn on their cameras? I have seen a lot of questions in the chat, in the Q&A. I think that today's 3 presentations are excellent, very insightful. Let me just take the privilege as moderator, starting by Bhutan, as this presentation just finished. So there has been a significant increase of imported cases in 2024 and also 2025, probably due to this outbreak in the border area in India. My question is that did the program in Bhutan know when there was an outbreak in India? How did you get information? How quickly were you able to get information of these Indian outbreaks, and whether you'll be able to put preventive measures in place before we seeing cases in Bhutan? Thank you.
Thank you, Dr. Hong, for your questions. Especially in the border area, it is very difficult to really know when there is an upsurge of the cases until when there is a full-blown outbreak. So usually it is very difficult for them. I think few thousands of cases were normal. So we need to be continuously asking them to at least share the number of the cases in the border area. But I think that things are improving with the relationship of the across the borders are improving as we know each other. So usually informally now they are sharing us as soon as they have a kind of increase of malaria cases in the border. But we also know which month the malaria usually comes in. It comes usually in the month of September, October, November, because in that period there is lots of festival in the southern belt where the people movements are very high. So we activate our control and preventive interventions more vigilant in this month. In spite of all this, we always see some spike of cases because the movement of the people are so high, and then sometimes it is very difficult to catch every people moving outside out of country and coming in. Sometimes it is very difficult. So we see always a small spike of cases during this period of time. So mainly because of the festival, they usually travel outside. Lots of the people were intermarriage, so they go out and come back, So these are some issues, but things are improving because now even in the border side, if there's a slight increase of malaria cases, they are informing us. So which help us actually in preventing, kind of the malaria across the border. So even this year, our cases, almost like 96% of the malaria cases are in border area only. So,
thank you.
but with all this 100% coverage, with IRS, LLIN, we still see few cases. That is something that we are not really been able to answer.
Yes, I think this continuous need to strengthen this cross-border collaboration, information sharing, and at a regional level, the support from WHO, but from also APMEN. I think that should be one priority at the regional level. Thank you very much. I see many questions in the chat. Let me just select them randomly. So this is a question to Dr. Pauly. Is the level of resilience adjust in your POR, for example, and does the POR foresee the system's capacity to deal with sudden catastrophic events or natural or man-made nature? Mainly just to deal with how do you deal with sudden catastrophic events in your POR strategy? I don't know whether you have any insight on that, and Dr. Pauly.
Thank you. Sorry, can you repeat the question again?
So the question is about whether your prevention of resettlement strategy will address any situation that you have a sudden catastrophic event or climate change or health system breakdown. For example, COVID-19 overwhelm the health system or you have a dengue outbreak. And for example, has the strategy for prevention of reestablishment consider such situation? That was the question.
Thank you for the question. It looks like a broad question, but focus to the field of the malaria prevention. I could answer that for the field in Cambodia, I can say that we are largely aligned with the WHO guideline. With the focus on the risk stratification, routine surveillance activity, prevention, and the response. And also the highlight the need of the intersectoral and inter-country cooperation as well. So if any happen regarding to the climate change, regarding to other outbreak, we have the intersectoral collaboration in the country, and then we are closer, and we are, how can I say, existing team in the country, especially in the COVID-19 in Cambodia. We are have the political commitment from the high level to lead and to contribute all any requirement to action to the PC. I can say like that. I don't know if it fit to the question or not. Sorry, I can say only like that.
Thank you. Thank you very much. I think that falls into the component of outbreak preparedness and emergency response. As Cambodia just started to piloting the POR strategy in some province, maybe we can ask these whether colleagues in Sri Lanka, whether they have any developed SOP or protocol for the outbreak response. And I don't know whether Dr. Indiwari, do you have anything to share with us in Sri Lanka? Is there any emergency response mechanism in place for malaria?
Due to floods, is that the question?
Yeah.
Sorry,
Yes, something like that.
Actually, yeah. The floods, there will be an effect for this mosquito breeding, and anyway, we are monitoring the receptivity. So even though the receptivity is high, we are not taking any measures to control mosquitoes. Only we are using that data to manage patients when there are positives are introduced. Then only to make the decisions on vector controls, we use this data. So there will be an effect on receptivity, and the health capabilities would be interrupted, but the central campaign would take all the measures to restore them quickly after the floods.
Thank you. Thank you very much. And another question is also to Dr. Indiwari. So can you elaborate more about this whole of government approach, the multi-sectoral collaboration in Sri Lanka, which is quite impressive. And actually, I am very interested to know what are the key parties or institutions that play a critical role in this multi-sectoral collaboration in Sri Lanka. For example, you have many stakeholders, traders, immigration, ports, security, private sectors. So who are the leading party in this multi-sectoral collaboration for the fight against malaria in Sri Lanka? Can you tell us a little bit more on that, Dr. Indiwari?
Actually, when the data, you can hear me now? Can you hear me?
Yes.
Yeah. Now, in Sri Lanka, we have identified all these risk groups in different districts. The risk groups are different. So in some areas, it's the gem traders. So they are like example in Kalutara, we have a lot of gem traders to African countries. In those areas, the regional malaria officers they have their team and they do all this collaborative work, and they have good close travel agents. So in some districts it's the pilgrims. So in especially the tri-forces, it's the people who go for these peacekeeping missions. Based on the vulnerability in the area, our regional malaria officers and their teams, they have a good close collaboration with identified risk group authorities. So like that we and also uh, when we are developing all these our strategic plans, we get everybody's inputs into our health. They are developing the national health policy. So we have included malaria also in the and the strategic plan also. There are so many intersectoral partners so there we all these collaborations, and we have a close contact, make them part of our program to support us in sustaining this elimination.
Thank you very much. So if I understand correctly, the anti-malaria campaign, the malaria team has an important role to bring the different partners together. Thank you.
Yeah.
So next, let me ask direct question to Dr. Polly. I think one audience asked how Cambodia is going to sustain the role of the village malaria workers or volunteer. How their role is going to be sustained in future? Are they going to be expanded their roles? Dr. Polly, can you share?
Thank you for the question regarding to sustainability role of the VMW after malaria elimination. Yeah, this is a very good question, and we are working on this. And I would like to let you know that the VMW program in Cambodia is not thinking now. We are thinking 5 years ago, since 2020, and we are pilot to apply since 2001 regarding to sustainability of the program after malaria elimination in Cambodia. And might be all of you know that VMW program has a long experience. It was 20 years ago, and it's very important to support malaria elimination. And now we are reached to malaria elimination. What is the role of that community health worker beyond after elimination? And as I mentioned earlier, that we are thinking 5 years ago about that, and we are pilot and we are integrating this village malaria worker with other program to be sustainable their role in the village. Some village in Cambodia, no malaria is many years, and VMW is the main job responsible for detection and case detection and malaria treatment, and there are no any more to do. So we are integrated with other disease program in Cambodia, such as dengue, NTD, native disease, APMEN, to provide their knowledge on health education, to be motivate their job or their function or their satisfactory in the village, to be maintained the service eastern system for the during malaria elimination and after malaria elimination as well. And now we are developing and will be finalized by the end of this year for the village malaria worker strategy during POR and look like beyond automatic elimination. We plan to integrate it with other existing health volunteer under Ministry of Health to be maintained the malaria service in the country until we get the certificate from WHO and still maintain the service requirement at all village Cambodia. This is my conclusion. We are in the progress of the pilot and in the progress expand integration role to be maintained service at the village level beyond the malaria elimination 2025 to 2030. Step my finish my answer.
Thank you. Thank you very much. We are approaching the end of the webinar. Let me just ask one final question to Dr. Topge. Just be very quickly. Can you just tell us how Bhutan's political will is going to be sustained to maintain malaria free status in Bhutan? And we know that you have lots of challenges in border, but what about the government's commitment? Whether this is a challenging for your country, Dr. Tauke?
Thank you so much, Dr. Hong. Especially currently, if you talk about the political commitment, we have a very, very strong political commitment for malaria elimination, and of course sustaining the malaria eliminations from the very top till the local level. We have a very strong commitment from the government as well as from the local leaders. They really want to keep their community free of malaria. So we have been advocating so long. The malaria is there in the other side of the border. We need to be vigilant and do kind of protective measures all the time. And then this has reached to the highest political level, so that any control and the preventive measure that the program wants to implement, they are ready to support us, even if the funds are not available. Maybe I think we need to really look which intervention is very effective. Then if you suggest this to the government, and then they are ready to help us. The commitment was very, very high as currently. So we are also motivated in working, because we get bashing every time, because they question us so often, no, how are you doing? Are we really going to achieve the eliminations? Questions that we get always. So the commitment at current level is very high, and we
Very
are
good.
hopeful that it will continue.
Very good. That's very reassuring. So thank you very much. Before we close, I would like to invite you to participate in this the quick Zoom evaluation poll. It will only take a few seconds, but your feedback is valuable for the APMEN team to better prepare future webinars. With this, I think we are entering the closing section. I would like to sincerely thank our excellent panelists, Dr. Topge, Dr. Paul Lee, and Dr. Gunaratna, for their excellent presentation and their invaluable insights. The experience was truly inspiring. I'm sure we all learned a lot from their presentation, their sharing the experience from their countries. Last but not least, thanks to all the participation and for your active participation and the contribution to this webinar. Thank you very much, and see you until next time. Bye-bye.
Bye.
And thank you to
Thank you so
Dr. Hong
much.
for moderating.
Thank you
It's
so
my
much.
pleasure. Thank you.